Let's see an NCLEX RN video based on care for critically ill patients with respiratory dysfunction. Before moving through this video, kindly go through video number 7 on NCLEX RN, in which ABG analysis is dealt in detail. A nurse is scheduled to take care for 3 patients in a trauma step-down unit. Which one should the nurse assess first based on this information from report? A 19-year-old, 2 days post motor vehicle crash, rib fractures and on CPAP for oxygenation issues, complaining of increasing chest pain. A 40-year-old, 1 day post-operative for a ruptured spleen following a motor vehicle accident, slightly confused about how he got to the unit. A 21-year-old, still comatose following a fall and flailed chest, remains stable on a ventilator and drug therapy for low blood pressure. A 60-year-old with a left femur fracture following a farming accident who is experiencing new onset of slight shortness of breath. So here, patient C, if you are seeing, you see that the patient is on ventilator, that is artificial airway, and also the patient is on vasoactive drug therapy. So this is the first patient who needs to be monitored. Secondly, the patient D, if you see, the patient D has got some shortness of breath which is of sudden onset, new onset. That may be because the patient may be experiencing pulmonary embolism. That is the next patient to be seen. The third patient, patient number A, the patient has got chest pain and it should be evaluated, but it is not unexpected with a patient having fracture of the rib and is usual for 1 day after severe car accident. And the fourth patient is patient number B. Here the confusion should be evaluated. A patient who is tachypneic for an extended period of time will demonstrate which of the following ABG results: respiratory alkalosis with hypercapnia, respiratory acidosis with a rising pH, respiratory alkalosis with hypocapnia, no changes in the results due to metabolic compensation. So the patient was having tachypnea for an extended period of time. During tachypnea, the patient will be blowing off carbon dioxide and hypocapnia will occur. And if hypocapnia is there, it will result in respiratory alkalosis. If it is hypercapnia, it would have been respiratory acidosis. So here hypocapnia, because of blowing off of carbon dioxide, that has resulted in respiratory alkalosis. The nurse caring for a patient with a closed pneumothorax will monitor closely for which of these complications: tension pneumothorax, flailed chest, cardiac tamponade, pulmonary embolism. So here you need to know what is pneumothorax. Pneumothorax is the collection of air in the pleural space. So here the patient has got a closed pneumothorax. Later on, the complication which the patient will develop is tension pneumothorax. If there is continued accumulation of air in the pleural space, that result in tension pneumothorax. Flail chest, that involves the fracture of the ribs in 2 or more places as a result of blunt or crushed chest trauma. So here it is not, flail chest is not because of closed pneumothorax, and cardiac tamponade occurs with blunt chest trauma. Pulmonary embolism is associated with immobility and also fracture of the long bones, and it is not because of pneumothorax. In assessing a patient's ABG who is diagnosed with early stage acute respiratory failure, the nurse would expect to see which of the following result. So acute respiratory failure is when one or both of the gas exchange functions of the lungs are compromised. The gas exchange functions of the lungs are oxygenation and ventilation or carbon dioxide removal. So the compromise of this function leads to hypoxemia and or hypercapnia, or it is also known as hypercarbia, that is increased PaCO2 level. And here let's see the options. pH is 7.38, PaCO2 48 mmHg, HCO3 24 mmHg, PaCO2 88 mmHg, saturation 96%. B is pH 7.48, partial pressure of carbon dioxide 30 mmHg, bicarbonate is 26 mmHg, partial pressure of oxygen 52 mmHg, saturation 90%. Third, pH 7.48, partial pressure of carbon dioxide 44 mmHg, bicarbonate is 30 mmHg, partial pressure of oxygen 70 mmHg, saturation 94%. pH is 7.35, partial pressure of carbon dioxide 40 mm of Hg, bicarbonate 18 mm of Hg, partial pressure of oxygen 74 mm Hg, saturation 98. So, the patient is in early stage of acute respiratory failure. So, in early stage of acute respiratory failure, the nurse has to anticipate that client's respiratory rate is elevated and the oxygenation would be reduced. So hypoxemia, you can see in this options, the hypoxemia, the value less than partial pressure of oxygen less than 60 mm of Hg is shown in second one, PaO2 52 mm Hg, and the partial pressure of carbon dioxide will be within or normal or near to the normal level. And also you can observe respiratory alkalosis. When you see the pH value, you can see the alkalosis. So this is what the nurse is expected in ABG finding. Please refer to the video number 7 for further understanding on ABG. The nurse understands tracheal deviation in a newly admitted patient to the emergency department is typically caused by which of the following? High hemothorax, tension pneumothorax, flail chest, and subcutaneous emphysema. Tracheal deviation is a classic manifestation of tension pneumothorax due to increased pressure in the pleural space, shifting the structures towards the opposite side. Subcutaneous emphysema is associated with air leaking into the tissues with the pneumothorax. Flail chest is associated with rib fractures, and hemothorax occurs with chest trauma and result in blood in the pleural space. So here the tracheal deviation is because of tension pneumothorax. After oxygen has been administered, the next priority intervention the nurse would initiate for a patient with a pulmonary embolus is the administration of which of these therapies? Normal saline IV fluid, IV heparin, platelet administration, antibiotics for inflammatory fever. So once a patient has been diagnosed with pulmonary embolism, the treatment of the patient of this acute pulmonary embolism is primarily anticoagulation. Intravenous heparin therapy is initiated with a symptomatic patient with any type of pulmonary embolism. So here IV heparin to be given. And later on when the patient is getting discharged, the anticoagulation continues with warfarin or Coumadin. And also IV fluids are indicated for the patient, but the first priority is IV heparin. Platelets and antibiotics, they are not indicated. A patient with a diagnosis of pneumonia complains of new onset of slight shortness of breath. Which of the following assessment findings would the nurse call to the primary care provider immediately? Select all that apply. The patient is voiding but the amount is decreased. The patient is sleeping more than usual or somnolent. There is a pink coloration to the skin. The patient's secretions are thin and milky colored. The patient thought it was the 3rd instead of the 5th of the month. So here the patient was in the diagnosis of pneumonia and now started with slight shortness of breath. When you are assessing, what all things you will find out so that you can inform the provider. When the patient is going to respiratory failure, at that time the patient will be having decreased level of consciousness or somnolence, and also when the carbon dioxide level is increasing, the patient may feel a pink skin coloration and also lethargy. Okay, and so here the patient is sleeping more than usual or somnolent. It's going to be an unconscious stage or decreased level of consciousness you can see, and also the color of the skin is getting pink, also indicate the patient's condition is deteriorating. The nurse understands oxygen therapy for a patient with COPD requires close monitoring because of which of the following: hypoxic respiratory drive, hypercapnic respiratory drive, acidotic respiratory drive, alkalotic respiratory drive. Here you need to understand, during normal ventilation is stimulated by the buildup of carbon dioxide in the blood. Chemoreceptors, they detect this elevated carbon dioxide state and the respiratory cycle is stimulated to breathe faster and more deeply. This is known as hypercapnic drive. This is normal for all humans. But in a patient with COPD, the body's chemoreceptors become less sensitive to this carbon dioxide because it is retained at a higher level. And this over time, the patient with COPD develops a hypoxic drive to breathe. That means it is the lack of oxygen in the blood that causes the patients to breathe. And when we are giving more oxygen concentration, what happens? The increased amount of oxygen may cause the patient to stop breathing. So for the COPD patient, hypoxic respiratory drive is the one which is happening for breathing, and we need to monitor the patient for this hypoxic respiratory drive. The pulmonary edema associated with ARDS, acute respiratory distress syndrome, is caused by increased permeability of the ACM. ACM is the alveolar capillary membrane, right ventricular failure with pulmonary hypertension, left ventricular failure due to poor oxygenation, fluid overload related to resuscitation in the first phase. So acute respiratory distress syndrome, it is defined by acute onset of less than 7 days, refractory hypoxemia will be present, and bilateral infiltrates ruling out cardiac pulmonary edema. So pulmonary edema is seen in acute respiratory system. It is associated with increased permeability of the alveolar capillary membrane. Because of the activation and release of the inflammatory mediators, there is a disruption of the alveolar capillary membrane. The alveolar capillary membrane becomes dilated due to the inflammatory mediators, and this disturbance allows fluid to move from the capillaries into the interstitial space and into the alveoli. This results in the pulmonary edema. The pulmonary edema is non-cardiogenic, that is caused by leak of plasma out of the vascular space into the alveoli and interstitial space of the lungs in acute respiratory distress syndrome. Fluid overload can complicate the picture, worsening the fluid leakage that is occurring due to the damage of the alveolar capillary membrane. So here the chest tube has become disconnected from the chest drainage system. Immediately cover the end of the chest tube with a sterile dressing. Immediately submerge the end of the chest tube in sterile water. Immediately reconnect the end of the chest tube with a new drainage system. Immediately page the provider to insert a new chest tube. If the chest tube becomes disconnected from the drainage system, immediately submerge the end of the chest tube in sterile water to preserve the water seal. This prevents the air from entering through the disconnected chest tube and reaccumulate in the pleural space. As quickly as possible, reconnect a new chest tube system. Be aware of the hospital policy. And if the chest tube becomes dislodged from the chest, apply a Vaseline gauze dressing and notify the provider immediately. Prepare for insertion of a new chest tube. So here the chest tube has just disconnected from the drainage system. So here we need to submerge the end in the sterile water. Covering the end of the tube would worsen the pneumothorax by stopping the removal of air from the pleural space. And a new drainage system would be connected, submerging the tube in water that allows the time to collect the necessary supplies. And a new chest tube is not necessary if the tube is still securely in the chest. So here immediately submerge the end of chest tube in the sterile water is the correct answer. You are caring for a client who sustained a chest injury following a motor vehicle accident requiring a chest tube and is receiving a morphine patient-controlled analgesia for pain. Which of the following would alarm you and initiate a call to the primary care provider? Sleepiness, restlessness and anxiety, itching at the IV site, minimal amount of bloody chest tube drainage. Restlessness and anxiety indicate hypoxemia, potentially due to the chest injury requiring investigation. Sleepiness may be due to the morphine PCA. Minimal amount of drainage and itching require evaluation but are not alarming. The nurse anticipates which of the following in the initial care of a patient with ARDS? Inotropic agents, fresh frozen plasma, anticoagulants, positive pressure ventilation. Know that in ARDS there is refractory hypoxemia. Mechanical ventilation or positive pressure ventilation is the primary treatment for the refractory hypoxemia for ARDS. And if we are giving this positive pressure ventilation, it will open the alveoli and improve the gas exchange. Inotropic agents may be necessary if the patient experiences hemodynamic instability. FFP and anticoagulants not required. A 19-year-old male admitted to the emergency department after sustaining injuries in a motor vehicle collision. He was not wearing a seat belt, but his airbag did deploy. He was conscious at the scene. Upon his arrival to the emergency department, vital signs are heart rate 115, SpO2 93% and temperature 99.3 degree Fahrenheit, BP 106/54 mmHg, respiratory rate 32 breaths per minute and pain is 10/10. And because of the saturation 93%, the patient is on 2 liter binasal cannula oxygen. He is complaining of pain across his sternum and on his left side. Inspection reveals a broad ecchymotic area across the front of his chest and a deformity along his left side in the region of his 5th through 8th ribs. With each inhalation, this part of his thorax moves inwards. Someone uses the phrase paradoxical movement to describe what is observed. Upon auscultation, no breath sounds are heard on the left side. A chest tube is inserted and 400 ml of blood is rapidly drained. This is something like chest trauma in which the features of flail chest you can observe. Here 3 or more adjacent ribs have been fractured and there is a paradoxical chest movement. Paradoxical chest movement is the hallmark sign that is associated with flail chest. That means with inhalation, the damaged area is moving inward and on exhalation, the section of that damaged chest is moving outward. And after stabilization of his injury, he is admitted to the ICU. The bleeding into the thoracic cavity has stopped, but the lung has not fully expanded. On the second day in the unit, it is noted that his pulse oximetry readings continue to decline in spite of increased FiO2 via 100% non-rebreather. He is tachypneic and tachycardiac. Then chest X-ray shows diffuse infiltrates bilaterally. An ABG shows the following: pH is 7.5, partial pressure of carbon dioxide 32, partial pressure of oxygen 50, bicarbonate of 28 while on 70% FiO2. It is determined that he has developed acute respiratory distress syndrome. He is intubated and mechanical ventilation is initiated. So after this injury, the patient is going for acute respiratory distress syndrome. He is managed with conventional mechanical ventilation with low tidal volumes to protect his lungs from injury. His fluid balance is managed judiciously. He is started on enteral feeding to support his nutrition. Initially, prone position is utilized to improve the gas exchange. He has frequent position changes and ROM exercises. After 5 days of careful monitoring and meticulous care, he begins to improve. His oxygenation status stabilizes and he is able to slowly wean from the ventilator. By day 7 in the ICU, he is extubated and out of bed to the chair. So this is the scenario. The nurse is aware that patient's hemothorax caused ineffective gas exchange due to which of the following mechanisms: anxiety due to the need of chest tube, blood collection in the pleural space reducing the negative thoracic pressure, pain related to chest tube placement, blood collection in the pleural space increasing negative intrathoracic pressure. So the patient has got hemothorax also. So in hemothorax, the presence of blood is there in the pleural space, and it occurs if there has been a laceration of the pulmonary vessel with a blunt or penetrating trauma. And like pneumothorax, as blood fills the pleural space, the negative pressure is lost. That means the patient is developing more positive pressure. And also the loss of blood from the vascular space results in hemodynamic compromise for the patient. So here if you are checking, the blood is there in the pleural space, that will increase the positive intrathoracic pressure, or we can tell it will reduce the negative intrathoracic pressure. That is what happens in hemothorax. The nurse expects to see what oxygenation and ABG changes for the patient with his acute respiratory distress syndrome begins to resolve. New onset respiratory alkalosis, an increasing partial pressure of oxygen and FiO2 ratio, resolving metabolic alkalosis, a decreasing partial pressure of oxygen and FiO2 ratio. So the patient is getting resolved from his acute respiratory distress syndrome. That improvement is shown by increase in partial pressure of oxygen and FiO2 ratio. That shows improvement in oxygenation. A decrease in the ratio, that indicates the worsening of the oxygenation status. So D is wrong. Then respiratory alkalosis is seen in early acute respiratory distress syndrome due to tachypnea, seen in an effort to increase the oxygen levels, and metabolic alkalosis is common with ARDS. The nurse understands that patient's initial refractory hypoxemia indicates what about the adequacy of a supplemental oxygen support. What does this refractory hypoxemia means? It is sufficient and the FiO2 can be reduced. It fails to maintain adequate oxygen saturation. It has caused signs of oxygen toxicity. It has caused alveolar collapse. Refractory means in spite of increased amount of oxygen levels, the patient's oxygenation status, it does not improve. This indicates worsening ventilation perfusion mismatch or shunt requiring more than supplemental oxygen for treatment. Oxygen does not cause alveolar collapse, that is caused by excessive secretions and pressure. So here the initial refractory hypoxemia indicate even though we are giving supplemental oxygen, there is a failure to maintain adequate oxygen saturation. Which of the following are priorities in patient's care? Select all that apply. Adequate nutritional supplementation, positioning with the good lung down, adequate hydration, maintain NPO status to prevent aspiration, elevate the head of bed. The client will need to be mobile as soon as possible or as soon as they are stable, we can say. So bed rest is not a choice for this patient. Nutrition is of paramount importance in this patient. If we position the patient with a good lung down, this will increase the blood flow to the lung on that side, and also it will increase the oxygen exchange. It will also allow for the maximum expansion of the affected lung. So one, nutritional supplementation we need to give. Another is we need to position the patient with good lung down. And hydration is vital to prevent the venous stasis and also maintain the urinary function. So adequate hydration should be provided, and we need to start feeding via NG tube. We should not keep the patient NPO, and we will have to keep the head of the bed up to prevent ventilator associated pneumonia. The nurse understands that the rationale for the administration of sedative and analgesic medication while on mechanical ventilation is which of the following? Select all that apply. Improve the respiratory effort, reduce the pain, increase the oxygenation consumption, increase patient ventilator synchrony, increase the mobilization. So when we are administering the sedatives and analgesic medication when a patient is on mechanical ventilator, it is to comfort the patient, to reduce the pain of the patient, and to decrease the oxygen consumption and improve the patient ventilator synchrony. Hope you understood the video on coordinating the care for critically ill patients with respiratory dysfunction, in which we dealt with chest trauma, we dealt with flail chest, pneumothorax, hemothorax in this chest trauma, then acute respiratory distress syndrome, we dealt with pulmonary embolism, and of course we dealt with acute respiratory failure. Hope you understood. Thank you so much.